Okay, so we're going to be talking about dealing with the worst case scenario and utilizing medical math to get you through it for a Crotalid snake envenomation from a juvenile timber rattlesnake bite in a dog. This is a crash intro to an emergency and critical care medicine case. I'm Kristin Lake, and I'm a veterinary emergency and critical care support staff member. I'm also the author of the Veterinary Technician's Guide to Emergency and Critical Care and the founder of VetMed Math, which tutors veterinary professionals one-on-one in medical math. We may have some time for some questions at the end. However, if not, you can always email me and it'll be available at the end as well at Kristin, Kristin, at vetmedmath.com. Okay, so let's get started. All right, this is our culprit, juvenile timber rattlesnake. So I tried to basically find a snake that was in Maine, but you guys have eradicated these guys over the last 30 years, but they are in neighboring states like New Hampshire, which is really close by. So some discussion topics. So timber rattlesnake envenomation clinical signs, our scenario with triage and triage questions, the physical exam, and also your initial laboratory analysis, methadone and Serenia drug dosage math, crystalloid fluid bolus math, venom vet antivenin titrated infusion math, and complications that arise in this patient. This is a theoretical case study. All right, also mathing your way through the complications. We're going to be discussing crystalloid fluid rates, venom vet antivenin titrated infusions, propofol IV bolus and CRI. You're calculating your reservoir bag size, your oxygen flow rate, your resting energy requirement, the enteral feeding CRI, the manual platelet count, urinary output with ins and outs, unison administration, fresh frozen plasma titrated transfusion, and clavamox. So the scenario, we're going to be checking in throughout with updates on the clinical status. At the end of the presentation, there will be a free download of chapter 14 and 19 from my book, The Veterinary Technician's Guide to Emergency and Critical Care, which is entitled Venom Vet Snake Envenomation Protocol, which was written by myself and another technician, Ashley Joyce, and it's free for all attendees and located at the end of the webinar in a link. Okay, so clinical signs of timber rattlesnake envenomation. The venom of the timber rattlesnake is largely hemotoxic and sometimes hemotoxic and neurotoxic, thus affecting both hematological and neurological symptoms. And so this is from human medicine, but I think that this gives a little bit more information basically as to like what our patients could really be feeling since they're nonverbal. So burning pain at the bite site, noticeable fang marks, and let's see here, skin discoloration, which could necrose, blistering, swelling at the bite site that slowly involves a wider region, thin blood from the wound, sensation of metallic taste in mouth. I don't think our patients would normally be able to tell us that, but human patients can. Twitching of the eye and mouth. So that would be a neurological manifestation. Paresthesias, chills and sweating, anxiety, breathing difficulties, nausea and vomiting, abdominal pain, blurred vision, necrosis around the affected region or limb, low blood pressure. That's really important that we want to continuously monitor in these cases because that's how venom works, is by causing hypotension. And then feeling faint and dizzy, weakness, and malaise. Okay, so some of the systemic signs and symptoms may include in some a bleeding disorder due to decreased blood platelets or thrombocytopenia, and then lysis, destruction of red blood cells. In some internal hemorrhaging, including blood in the urine, bleeding from recent wounds, mucosal bleeding from the nose, eyes, ears, GI tract, and anemia due to spontaneous bleeding. Acute kidney injury or kidney failure is very unlikely. Neurological symptoms are present again in timber rattlesnake bites in some cases. There's technically like 3 subtypes of this snake, and some of them are hemotoxic, Some are hemotoxic and neurotoxic, and then some just have the neurotoxin, I believe. Okay, so this is our scenario. A 4-year-old, 25-kilogram male neutered mixed breed dog named Walter presents to your ER in Sanford, Maine from Rochester, New Hampshire with bite wounds from a juvenile timber rattlesnake that the owner believes they successfully identified after seeing the snake attacking the dog in the owner's backyard at around 5:30 p.m. when the owner got home from work and let the dog out to go to the bathroom. This is not the first incidence of timber rattlers on the owner's property, which gives more credence to the owner's proper identification of the snake in question. Though they're endangered, the owners have debris on their property in which the snakes like to use as dens. The patient has been triaged at 8:45 p.m. according to protocol guidelines to reduce movement as much as possible. So the dog has been placed on a gurney and strapped to reduce the spread of venom. Walter does not seem to need emergency stabilization at the presentation. So the stable snake envenomation patient protocol and triage should be performed, which we'll see here. So triage and history taking of these patients. If they're stable, have teammates gurney the pet inside and prevent the animal from mobilizing. Time's a factor, and venom can reach central circulation faster if the animal's mobile before treatment is initiated. Take comprehensive history from the owner, including description of the snake if seen in areas where bite wounds may be located. We need a time frame of envenomation and time elapsed since the envenomation. If any first aid was administered, what kind as well. Our anti-venom shows that the longer time has been elapsed, basically, since they are able to get to care, the less effective it's going to be. Names and dosages of any medications given and any medications regularly taken and for what conditions. Previous pertinent medical history. Symptoms displayed in time of onset and longevity. Are they showing neurological signs? Are they not? Full TPR with weight, full examination, physical examination by the doctor, full body check for bite wounds as well. These are very small usually, so we can easily miss them. So just be 200% sure before you place a catheter that there are no bite wounds in that arm. Also trace with black magic marker the affected areas and monitor the sites regularly and update the tracing to track the swelling, local edema, and progression of local symptoms. Okay, so your physical exam. You begin with your physical exam with vitals and the temperature is slightly elevated at 102.9. The heart rate's 124. Respiration is pant. Mucous membranes are slightly injected and there's blood present in the mouth. Your physical exam also reveals that the dog was bitten on the left carpus with swelling and a small amount of blood is present. On the left chest with superficial swelling and a small amount of blood present as well. And he's been bitten on the tongue where blood is present in the mouth along with some local swelling. Your lab analysis. You immediately ask your technicians to take a Doppler blood pressure and draw blood for a coagulation panel and a blood smear to look for the extent of the chenocytosis. Your technicians come back 15 minutes later and let you know that systolic blood pressure is 84, PT is deranged, showing some prolonged clotting times, and APCT is within normal limits. They tell you that about 95% of the red blood cells are chenocytes from the blood smear. Now, it's really important to run the blood smear immediately because crenation can occur if the blood has been sitting for a while. So chenocytes look like crenation. So we need to be able to differentiate between those two. So we need it run immediately. All right, so owner discussion. You speak with the owner and review the test results and let them know that you believe this was a true bite and not a dry bite, and believe Venom Vet anti-venom will help to fight against the venom's toxic effects, and explain that sometimes we can see reactions to anti-venom, which can be treatable in hospital, but it's a risk associated with treatment. You also explain that juvenile rattlesnake bites are typically worse than adult rattlesnake bites, as they have yet to be able to control the dosages of venom they inject, and we could see a variety of issues related to a severe envenomation. You let the owners know that since timber rattlesnakes have been extirpated from Maine that the hospital only keeps 2 vials of antivenin in stock at a time, and you hope this will be sufficient to treat Walter. Otherwise, he may need to be transferred to a hospital with more antivenin on site. So we start our treatment. You receive the owner's informed consent to your plan of care and immediately begin calculating the VenomVet antivenin infusion over 1 hour for your patient, while you order your techs to place 2 patent IVCs in non-affected limbs to deliver a crystalloid quarter shock bolus aliquot over 10 minutes to help with Walter's hypotension while you calculate the VenomVet infusion. You also ordered an oscillometric blood pressure after the bolus to be taken. Your techs place an IV catheter in the right cephalic vein and the right lateral saphenous vein to also give PICC line access and reduce the amount of times Walter needs to be poked. So regular 0.9% saline will be used with a 3 syringe technique to draw blood from the PICC line, as heparinized saline may worsen his coagulopathy. So you order your techs to then give 10 mg per mil, methadone at 0.2 mg per kg for pain management, and Serenia 10 mg per mil at 1 mg per kg for nausea, anti-emesis, anti-inflammation, while getting set up for the VenomVet antivenin infusion. The techs place the PICC line using sterile technique and report it bled a bit more than usual, but it's working well. So the medical math involved here. So our quarter shock bolus aliquot of a crystalloid fluid to combat the hypotension. A 90 mil per kg quarter shock bolus aliquot is typically what we want to use for a dog or so. This can differentiate if they have cardiac or renal impairment. It's going to be lower. So keep that in mind when they tell you any previous pertinent medical history if they have those things. Weight 24 kgs. Time, we want to go ahead and give that that bolus over 10 minutes. So basically, this is how we calculate that: 90 mils per kg times 24 kgs. We get our total shock bolus, 2160 mils, and then 2160 mils divided by 4, because we want a quarter of that. 540 mils, that's our quarter shock bolus aliquot and our VTBI that we want to program into our pump. So now we take into consideration our time. 60 minutes divided by 10 minutes equals 6. So that's a unit of time. So 540 mils times 6, our rate's going to be 3240 mils an hour. If you're lucky enough to have a pump in hospital that can actually program that properly, wonderful. If not, you're going to be doing 999 over 540. Okay, your methadone bolus. So dose times weight divided by concentration here to get our methadone and our Serenia. All right, so our crystalloid fluid rates running concurrently during the infusion of antivenin. We are not accounting for a dehydration deficit here, nor are we accounting for ongoing losses since we're presenting without vomiting and diarrhea. So I work with vets that like to start out at 1 times maintenance, which is 60 mils per kg per day. So that's what I'm working off of here for Walter. So 60 mils per kg per day times 24 kgs equals 440 mils per day. Over a 24-hour period, that's 60 mils an hour. So we want to factor in that the antivenin infusion is 100 mils. We rarely calculate, how much drugs or, saline that we're putting into patients, but fluid creep can occur if you don't take these things into account, especially if you're giving something like doxycycline that is usually a very large volume. 1440 mils per day minus 100 mils for the antivenin infusion, 1340 mils per day. And then over 24 hours, we're going to change our rate from 60 mils an hour to 56 mils an hour after they've received the antivenin infusion. So your technicians report that the quarter shock bolus aliquot blood pressure is 95/70, MAP of 74. You're happier with these numbers, but we'll continue to monitor closely for hypotension throughout the VenomVet infusion. However, you're noticing increased swelling of the tongue, and ask your technicians to set up for an emergency intubation should the swelling continue to progress, compromising the airway with a mechanical obstruction while they set up the Buretrol for the Venom Vet antivenin infusion for administration. So I like using Buretrol for Venom Vet. Basically, it's 10 mils of Venom Vet to 90 mils of a Cristoid fluid, and it's very easy to give that way. So this right here is our calculation for Venom Vet. Our dosing range is about 0.025 mils per kg per minute up to 0.1 mils per kg per minute. You start low and slow like a blood transfusion, increasing the rate every 10 minutes until the max rate at 0.1 mils per kg per minute is achieved. Again, 10 mils of antivenins and 90 mils crystalloid, 100 mils total over an hour is usually sufficient. So essentially, this is all the math worked out, how you go ahead and continue doubling the rates from the starting dosage rate, and then getting up to the 0.1 mils per kg per minute, where you just go ahead and continue where you're at. So our rate would be 36 mils an hour with a VTBI of 6 mils for the first 0 to 10 minutes. And then we bump that up and double it to 72 mils an hour, which is going to give us a 12 mil VTBI. And then again, 72 mils an hour and 12 mils. This is so that everything basically gets into the patient over the 1 hour. So we're going to go all the way up to 144 mils an hour, and that's going to give us 24 mils VTBI each time. And we're going to get about 102 mils. 2 mils is negligible, so you can work with that. All right, so the Venom Vet antivenin infusion gets underway with the calculations you performed with the technician reprogramming the pump at the end of every 10-minute increment when the pump sounds with the rates and VTBIs you calculated for this patient. Your technicians have been advised to shave and clean the wounds with diluted chlorhexidine scrub during the infusion. Draw around the current swelling with magic marker and place a time next to the ring, and to utilize the snakebite severity scoring system at each 30-minute increment. Your patient's scheduled for vitals every 5 minutes for the first 30 minutes of the infusion. The patient makes it through the first 3 rounds of the Venom Vet infusion without any major changes in their vitals. Their crystalloid maintenance fluid is running concurrently and maintaining the blood pressure within low normal parameters. You'll continue to monitor the blood pressure and advise to decrease vital checks to every 10 minutes and let the infusion flow while you check on some other patients. This is a snakebite severity scoring system. So you want to perform this every 30 minutes during the infusion, except for the hematological section, which is coags. We're not going to repeat coags during the infusion itself. And then you're going to extend it to every 4 hours after the infusion and repeat the coagulation profile and blood smear at that time. But this can basically give us a pretty good idea if things are worsening or if they're improving. So at 11 p.m., Walter finishes his Venom Vet antivenin infusion without incident and scored well on his snakebite severity scoring system, except in the local wound portion. His wounds on the left carpus and the left chest, which have been clipped and cleaned, are swelling, along with his tongue, which is now hanging out of his mouth to the side. You discuss options with the owners and let them know that if the swelling does not stop soon, that you'll believe intubation may be necessary to protect his airway. They agree to do whatever is best for Walter and pursue continued treatment. His wounds are still oozing thin blood as well, including his tongue. You order for your techs to closely monitor his respiration rate, the local wounds, and to let you know if the swelling has progressed in 20 minutes and to redraw for coags and a blood smear at midnight. The techs report 20 minutes later that the swelling has not ceased and his left carpus is now twice its usual size. His left chest is visibly more swollen and his tongue is also visibly more swollen. You discuss with the owners that you don't want to wait for Walter to go into respiratory distress before making the decision to intubate him. You might not be able to at that point, and explain that he can comfortably be kept on a propofol CRI to sedate him for the intubation to protect his airway. His owners agree with your care plan and understand the finances involved in maintaining an animal on a propofol CRI with one-on-one nursing care until he's extubated. You let them know that you hope that the laboratory test will come back and show the antivenin is making some headway on a cellular level, and that it's your hope to have him intubated for only a few hours until the swelling starts to subside. But he could be intubated for longer depending on how he responds to treatment. They understand the risks involved, but decide to move forward. So you order your techs to pull up 4 mg per kg of propofol titrated to effects for the intubation, and then have a 4-hour 0.1 mg per kg per minute propofol CRI on standby for after the IV bolus. Your techs utilize a 3-syringe technique with 0.9% saline flush to get their blood draw and begin to run the labs that you ordered. Anna, Walter's one-on-one technician for the night, helps you to intubate. All right, so what medical math is involved here? We need to calculate our reservoir bag size because we want to go ahead and keep this patient oxygenated well, and while his airway is compromised, basically. So we need to go ahead and calculate his reservoir bag size. So it's between at 1.44 liters and 2.88 liters. So we just basically, if it's over 1, we're going to go to 2. If it's over 2, we're going to go to 3. But so a size 2-liter or 3-liter reservoir bag would be needed. The oxygen flow rate for rebreathing circuit, 25 to 50 mils per kg per minute. So his oxygen needs to be at about 0.6 liters per minute to 1.2 liters per minute. No less than 0.5 liters per minute for any patient, though. All right, so the propofol IV bolus, again, dose times weight divided by concentration, 9.6 mils of propofol IV for 4 mg per kg. Our propofol CRI. So order, weight, rate, time, concentration. These are some of the things that you'll need as your givens to kind of guide you through it. So 0.1 mg per kg per minute times 24 kilograms gives us 2.4 mg per minute. 2.4 mg per minute times 60 minutes an hour gives us 144 milligrams an hour. 144 milligrams an hour times 4 hours is 576 milligrams. And finally, 576 milligrams divided by 10 mg per mil is 57.6 mils of propofol pulled up for this CRI for 4 hours. Now, to get his rates, we want to go ahead and take the total volume of drug divided by time, and that gives us our rate. So 14.4 mils an hour is what we'll run it at. All right, so intubation of Walter successful with about 3 mg per kg of propofol actually administered during titration, and the propofol CRI was initiated. Now, his midnight labs, PT and APTT, are now both prolonged. Blood smear indicates about 75% of red blood cells are echinocytes. It was 95% before, showing some effect of the first vial of antivenin, but not nearly enough. You discuss the findings with the owners and opts for a second vial of antivenin, given the severity of the envenomation and the locations affected. You let them know that you believe this will give Walter the best chance possible, and they agree. All right, so Walter currently has a PICC line for blood draws placed in the right lateral saphenous vein. The right cephalic IV catheter is being used for the propofol CRI, which we want a dedicated catheter for. And so we don't want to necessarily poke these patients a million times, but you do want to order a third IV catheter to be placed in the left rear lateral saphenous vein, since the propofol and antivenin should just have dedicated IV catheters. And since a central line would be contraindicated in an intubated patient with a local bite wound with edematous swelling to the left chest, it's not a good thing to try to start poking around in there. The left lateral saphenous IV bleeds a bit more than normal, but placement successful. You decide to DC the crystalloids during the VenumVet antivenin infusion as well. A second vial of the antivenin is now to be administered over 1 hour in the left lateral saphenous IV catheter. Walter is handling his propofol CRI well and is having his vitals monitored every 5 minutes by Anna while sedated. Anna also completes the snakebite severity scoring system throughout the infusion for vial number 2. The local wounds portion of the snakebite severity scoring system is incrementally improved with the administration of the second vial, which completes at 1:20 a.m. You reinstitute the crystalloids in the left lateral saphenous after the VenumVet. All right, so again, here's our VenumVet math. And if you guys want to take a look at this again for another vial, I'll leave this up for a second. Okay, snake bite severity score again. All right. Your next check for lab work is at 4 a.m. and refill of the propofol CRI will be performed as well. At 3:30 though, Anna finds petechiation on the ventral abdomen and between Walter's legs. The order for labs to be drawn now instead. Utilizing the 3 syringe technique, she easily gets good samples for coags, a blood smear, and a CBC Chem17 lights panel. Coags are still deranged and prolonged, but there's a small improvement. You tell Anna to gear up for a possible FFP transfusion, fresh frozen plasma, if 8 a.m. coags are not within normal limits or if the petechiation worsens. The blood smear indicates 50% of the red blood cells are echinocytes, so the antivenin is having a positive clinical effect that we can measure. The CBC shows mild anemia, moderate thrombocytopenia confirmed with a manual platelet count, and some liver values are deranged on the chemistry while electrolytes are normal. All right, so how do we perform a manual platelet count? So we're going to go ahead and add the platelet count from 10 fields of view at 100x magnification, divide the sum by 10, multiply by 15,000 for the low end, multiply by 20,000 for the high end. The reference range is greater than 200,000 for cats and dogs, or you can go ahead and say about 10 to 24 per high power field at 100x. So this is the calculation for that. So we want to take into account the second vial of antivenin that we gave and change our fluid rate again. So we were at 1340 mils per day prior, so minus another 100 mils that's already been delivered, 1240 mils per day over 24 hours, 52 mils an hour. So this is about 52 mils per kg per day. Propofol CRI, again, since it needs to be refilled, you need that math. So here it is. All right, so our scenario again. You call the owners at home to discuss the blood work at 7 a.m., letting them know that the next round of blood work is at 8 a.m. before your shift ends, and you'll be transferring the case to the day doctor, and you've had your techs place an NG tube for enteral nutrition and a urinary Foley catheter for urinary monitoring, since we do not know when Walter will be able to be extubated yet. You discuss the possibility of needing an FFP transfusion if the coagulation profile parameters do not improve by 8 a.m. They're shocked and saddened of Walter's state, but want to continue doing all they can to help Walter and agree to the transfusion if it's needed. All right, so what do we need for an enteral feeding CRI? We need to calculate our resting energy requirement. Now, there's 1.6 times RER and all of these different things for different stages of life. But for Walter, we're just going to use 1 times RER and keep it there. So essentially, on your calculator, it's easiest to use the scientific side and the XY function in order to go ahead and get that exponent of 0.75. So that's how that's calculated there. So 1 times RER to start is 759 kilocalories per day. Over 24 hours, 31.625 kilocalories an hour. 1 kilocal per mil of our Criticare or whatever Royal Canin you're going to use. It's usually about 1.2 kilocalories per mil. It'll say on the bottle times 31.625 kilocalories an hour is 32 mils an hour, basically. So 32 mils an hour times 2 hours, because our syringes are only so big, we can extend a 60 mil syringe a little bit further back to get 64 mils drawn up for 2 hours at a time. All right, urinary output. This is really important. So we want to calculate our ins and outs. So we're at 56 mils an hour of crystalloid fluid for 4 hours. So 224 mils over 4 hours is basically what we get, or you can look at the total volume infused on your pump. Outs, 124 mils of urine with hematuria. So that's a negative clinical sign, and we definitely want to tell our doctor that. So 124 mils divided by 24 kgs, so you're going to get 5.167 mils per kg, 5.167 mils per kg divided by 4 hours, 1.29 mils per kg per hour. Generally, we want to be between 1 and 2 mils per kg per hour. Sometimes you'll see much higher in like block cats and things like that. Okay, so the 8 a.m. vitals, lab work recheck, propofol CRI, and morning rounds are here. The PT and APTT are holding steady after the second vial of Venom Vet antivenin, but are still both prolonged. Petechiation is now worsening. However, Walter's blood pressure is now 80/64 with a MAP of 59. He's still on his propofol CRI, and his tongue swelling has remained static for the last 2 hours, but his propofol needs to be refilled along with his Criticare and enteral feeding CRI. Walter also needs his ins and outs performed again. That's about every 4 hours that you want to do that. During rounds, you hand over your math from earlier to save time for the day shift crew. You're rounding over his case to your day shift colleague and discussing options for the day. You both agree to institute the FFP transfusion to assist with the low blood pressure and coagulopathy. You call the owners one last time before turning the case over to your colleague and let them know of your plan, of the plan that you'd like to institute, and explain that hypotension is the sequela of the venom, as that's how venomous snakes are able to quickly immobilize their prey. And poor Walter had a copious amount of venom injected into him since it was a juvenile with poor control over the amount of venom they inject. The owners agree to the FFP transfusion, and we'll come back later to we'll come back to visit after work. Excuse me. All right, so your colleague suggests 30 mg per mil unison at 30 mg per kg every 8 hours for any primary and secondary infections and bite wounds, and to DC the crystalloids during the transfusion, which you agree with. Blood typing's underway, and the day shift tech informs your colleague that Walter is DEA 1.1 negative. I still use 1.1 colloquially, basically, but it's DEA 1 these days, which is great because the hospital only has 1 double unit of negative FFP. The techs start delivering the replenished propofol CRI and unison while the FFP is in a warm water bath. All right, here's our propofol CRI again, and unison. So how do we go ahead and calculate our unison? So 30 mg per kg times 24 kgs, 720 milligrams, 720 milligrams divided by 30 mg per mil, 24 mils IV over 20 minutes, 3 times a day, every 8 hours. So an easy way to think about it, since it's 30 mg per kg, 30 mg per mil, it's the patient's weight. So 60 minutes divided by 20 minutes, we usually want to give unison over 20 to 30 minutes. Some places do 15, but I like to do about 20 minutes. So that gives us 3, which is a unit of time. So we're going to get mils per hour in the next portion of our answer. So 24 mils times 3 equals 72 mils per hour. So we want to go ahead and run 24 mils of unison at a rate of 72 mils an hour. All right, again, our RER, if you want to take a look at that. All right, so there's been a change in the urinary output. Our outs, 132 mils of urine with hematuria. Again, 132 mils divided by 24 kgs, 5.5 mils per kg. 5.5 mils per kg divided by 4 hours, 1.375 mils per kg per hour. So we're still within normal limits on our urinary output. We're just concerned about that hematuria. So our FFP transfusion, the dosage is 10 to 15 mils per kg of FFP for our canine, and the order is 10 mils per kg for this dog. Weight is 24 kgs, time 4 hours. So 10 mils per kg times 24 kgs gives us 240 mils of FFP. That's our total volume that we need to deliver. So 240 mils divided by 4 hours, because we want to go ahead and give this over about a 4-hour period. You can do it much faster than that if you have a patient that is critical and absolutely needs it immediately. Walter, we've got a coagulopathy and whatnot. We're working on it. The 4 hours should be just fine. So 60 mils an hour gives us a jumping off point for our first 15-minute increment rate. So we want to divide by 4 because there are 4 increments that are in an hour. So 4 15-minute increments. And that starts us out at 15 mils an hour. Just like a packed red blood cell transfusion, you want to start low and slow because the transfusion reaction is basically a transfusion reaction is directly equated to the volume infused. So you're going to get a more severe reaction in patients that have had a larger volume of blood, basically of blood products put into them. It's going to be a more severe reaction. So 15 mils an hour times 2, because we want to go ahead and double in each 15-minute increment, we want to go ahead and double the rate. So, and then 30 mils an hour times 2, 60 mils an hour, 60 mils an hour times 2, 120 mils an hour. So at this point, the first hour is done. We want to check our pump and for the TBI and recalculate the transfusion rate to administer the remaining volume, or we want to calculate the TBI as follows. So 15 mils an hour divided by 4 hours, that gives us a VTBI, a TBI of 3.75 mils in the first 15-minute increment, and then it doubles basically 7.5 mils, 15 mils, 30 mils as we continue to go ahead and double our rate. So we want to add all of those together, and that gives us a total volume infused of 56.25 mils. So 240 mils minus that 56.25 mils that was delivered in the first hour gives us 183.75 mils remaining VTVI. So 183.75 mils divided by 3 hours, which is what we have left. So we're going to run at 61 mils an hour for the remaining 3 hours. Now, 15 mils an hour divided by 24 kgs is a 0.625 mil per kg per hour to start. We want it between 0.5 and 1 mil per kg per hour to start. That's what I have always been taught when it comes to transfusion medicine. I believe Cornell does it that way. There's some people that do it between 1 and 2. I like low and slow. All right. This is our FFP titration table. Basically, you make it nice and easy for yourself. Pretty good to go. So if you guys want to take a look at this for a second. All right. Okay, back to our scenario. Midway through the transfusion at 10 a.m., Walter's enteral feeding CRI is refilled. It's now noon, and your daytime colleague has watched over Walter's FFP transfusion, which he took well without incident. He's also seen a decrease in the local tissue edema on the left carpus and left chest, and has noted a vast decrease in the swelling of the tongue, and feels it's safe to DC the propofol CRI and extubate. Walter wakes up a little groggy and sore, so another dose of methadone is given IV. Walter is being good about his NG tube, and the techs take him outside to relieve his bowels with his urinary Foley still in place, and continue to monitor his ins and outs and the quality of his urine because we had that hematuria. He's due for a repeat coag panel at 2 p.m. All right, so another dose times weight divided by concentration, methadone bolus. Here we go. At 2 p.m., Walter's PT and APTT are within normal limits after the FFP transfusion. Walter's enteral feeding CRI is replenished. Another dose of Unison's given at 4 p.m. and his enteral feeding CRI is replenished again. Remember, it was basically every 2 hours. Your daytime colleague calls the owners with the good news, and they come to visit at 6 p.m. and they're present when you arrive for your shift. Walter's NG tube has been removed. All right, so this is basically since we were replenishing his enteral feeding CRI, That's where we're at. And then the unison, again, since it's TID, we've got our 72 mils an hour and 24 mils of unison given. All right, so you're glad to see that Walter's extubated and awake with much less swelling and edema than the previous shift. You round with your daytime colleague and they'd let you know that the FFP transfusion went off without a hitch and his pain is being maintained well with intermittent methadone boluses. You perform your physical exam again, view the petechiation sites and speak to the owners and let them know that you'd like to monitor him until 9 p.m., which is 24 hours post-presentation to see how he does. And at that point, if he eats on his own, he can go home and return tomorrow evening for a repeat coagulation panel to ensure he's not having any further negative effects from the envenomation. They're elated, they agree. You decrease his crystalloid fluid rate from 52 mils per kg per day to 26 mils per kg per day, which is half before DCing them. All right, so to go ahead and decrease his crystalloids, that's running at 52 mils an hour. You could literally just do 52 mils an hour divided by 2, 26 mils an hour, or take the long way. All right, so Walter eats some wet ID on his own and walks around the area by his kennel in the treatment area on his own, gingerly, but without any CP or other neurodeficits. And you decide to redose his methadone before he goes out the door. You order for the urinary Foley catheter to be removed, along with his IV catheters and PICC line to prepare him to go home. You take a look at his urinary production numbers and see that his urine has cleared up from hematuria post-FFP transfusion, and he's been producing about 1.5 mils per kg per hour of urine, which is right on target. There's no signs of fluid overload. We've been very cautious about that. You perform one last snake bite severity score and see that he's improved greatly, and despite the local wounds and a small amount of edema present, his score is almost perfect. So since we are decing the unison, going to orals, you prescribe Clavimox 375, 1 chewable tablet BID times 5 days to go home with. So methadone bolus before he goes out the door. Clavimox, he's basically a little bit under at 330 milligrams, but you increase this to 375. So 1 tablet BID times 5 days, at 10 tablets total. All right, so Walter returns the following evening for another coagulation profile, and he looks great on physical exam in comparison to presentation. His coagulation parameters are within normal limits, and you clear him to return home with the owners and to stay away from snakes. The owners say they have started clearing their yard of debris where the snakes can den and are monitoring Walter whenever he's in the yard. They're grateful for your quick diagnosis, your prompt treatment of Walter, and give you a thank you card for you and your staff, and brought homemade cookies for the hospital staff. Looking back on this case, you realize that despite Walter's severe envenomation, you felt confident and control the situation because of you and your colleagues' ability to calculate the treatments that would help him when he needed them most. There were some scary moments like intubating him and maintaining him on a propofol CRI for hours, but he never had any neurological manifestations, which you're grateful for, and now have even more experience treating severe hemotoxic snakebite envenomations and feel even more confident for the next one that prevents on your service. So great job, team. All right, so that is the end, and this is my book here. This is where you're going to access the Chapter 14 Venom Vet Snakebite and Envenomation Protocol and the citations chapter of the Veterinary Technician's Guide to Emergency and Critical Care. Just go to tinyurl.com. I don't know if that's a / or a backslash, but it's a slash. YE6K4SX9, all lowercase. This is my book, and it is coming out within the next month. VetMed Math, this is my company. If you feel like you need more practice in medical math, like today was not a breeze for you, I am happy to give you one-on-one tutoring in veterinary medical math. So just go to my website and we can go ahead and get started. If you guys have any questions regarding this presentation or anything regarding VetMed Math or the book, please email me at Kristin@vetmedmath.com.